Hello and welcome. Thank you for joining us for this recorded webinar, State of the Art in Lung Transplantation and Challenges for the Maritime Canadian Patient. We were honored to host two of Canada's leading experts in lung transplantation, Dr. Shaf Keshavjee, world-renowned lung transplant surgeon and Chief of Innovation at UHN, and Dr. Aman, Sidhu, Medical Director of the Toronto Lung Transplant Program. It was a privilege to hear directly from the leadership team of the Toronto Lung Transplant Program, one of the top programs in the world. This presentation offers critical insights into the latest innovations in lung transplant care and sheds light on the unique challenges faced by patients here in the Maritimes. It's exciting to see innovation that we hope will open doors for more patients to access this life-saving surgery. On behalf of Lung and SPEI, thank you again to Shaf and Sidhu, and thank you for tuning in. Here at Lung and SPEI, lung transplant has always been a big priority for us. Over the years, we've done a variety of different things where it's advocating for more funding for patients to be able to go to Toronto and have their surgery. We ourselves have been very fortunate to have a donor that has earmarked funds for our lung transplant support fund. It's a modest amount, but it is a little bit of a help. It is very precarious, that funding, as we are always looking for other avenues to raise more dollars that we have to supplement the cost for patients to go up. But another part of our role when it comes to lung transplant is education, and that's what we're here for today, and bringing the community together. We're very fortunate to have access to an array of talent from our lung transplant community. And one of those persons is directly related to Lung and SPEI, and she's on our board, and that is Dr. Allison Wallace. Her clinical practice involves the surgical management of the benign and malignant diseases of the lung, pleura, and esophagus using minimally invasive and robotic techniques. As a surgeon scientist, Dr. Wallace studies the molecular mechanisms by which smoke and other environmental exposures, such as radon, promote the development of lung diseases like cancer and COPD. So we're very fortunate to have Dr. Wallace with us, and I'm going to pass it over to her to introduce the remaining folks that are in that array of medical talent that we have. Allison.
Thank you very much, Robert. So good evening, everyone, and welcome. I'm truly delighted to be here with all of you tonight for what promises to be an inspiring and thought-provoking presentation on the state of art in lung transplantation and challenges for the maritime patient, presented by Lung and SPEI. It's an honor for me to introduce our speakers, two of the most respected experts in the field of lung transplantation in Canada and beyond. First of all, Dr. Shaf Keshavjee is a name well known to many of you. He is globally recognized leader in thoracic surgery as well as lung transplantation, and currently serves as the Chief of Innovation at UHN in Toronto. Dr. Keshavjee has been instrumental in revolutionizing lung transplantation through his pioneering work on ex vivo lung perfusion, a technology that has dramatically expanded the number of lungs available for transplant. On a personal note, I had the privilege of training with Dr. Keshavjee during my thoracic surgery fellowship in Toronto. His commitment to patients and passion for innovation left a lasting impression on me, as I know it has on the countless others who have trained with him. So thank you very much for joining us tonight. We look forward to your inspiring talk. I'll also introduce our second speaker at this time. Joining him tonight is Aman Sidhu, Medical Director of the Toronto Lung Transplant Program. Dr. Sidhu is a dedicated clinician and leader who specializes in advanced lung disease and transplantation. Our work focuses not only on optimizing outcomes for transplant recipients, but also on addressing disparities in access to care, something that is especially relevant to our conversation tonight as we think about the unique challenges faced by the Maritime patients. So just before we begin, a few quick housekeeping notes. We'll be holding a Q&A session at the end of the presentation. So please enter your questions into the Zoom chat and we'll do our best to address the questions as time permits at the end. And with that, again, thank you all for joining us this evening, and Dr. Keshavjee.
Thanks, Allison, for that introduction. Can everybody hear okay? You're hearing it? So we're going to give you a whirlwind tour of state-of-the-art in lung transplantation, what we do now, and really the fact that we are the Lung Transplant Center for Ontario and all of the Maritime provinces, and some of the challenges that we face together. So I have some companies that we have spun out of the research we do, and I will be covering using some of that in my talks. I think one of the important things to note, though, is that we did the first successful lung transplant in the world in 1983, and that's a YouTube video called Number 45 Lung Transplant, because the operation had been tried 44 times worldwide and not been successful in the long term. We did the first bilateral lung transplant in 1986 and the first lung transplant for cystic fibrosis in 1988. That's the gentleman in the middle of the picture there. So we've done over 3,000 lung transplants to date. About 85% of them are double lungs or bilateral lungs, 15% single lungs, and about 1% are heart lung transplants. We've also done lung liver transplants and lung liver pancreas transplants and some retransplants as well. When you look at the indications for lung transplantation, the majority of them are for pulmonary fibrosis or interstitial lung disease. And in fact, when you look at it over time, the green slice of the pie here, you can see that right now, idiopathic pulmonary fibrosis accounts, or interstitial lung disease, accounts for 60% of the lung transplants we perform. And when you look at single lung transplants, the number of single lung transplants have increased over the decades because in interstitial lung disease, you can treat patients equally well with a single lung transplant, and that has been increasing as an indication over time. One of the things we did was we developed the ex vivo lung perfusion system, where this is a schematic of it here, and in the bottom right is the device that we've built and commercialized to scale this to the bedside and around the world. But basically, you put the lungs on in a chamber in the middle there. It's ventilated by an ICU ventilator. It's run by a pump, which is basically run backwards to remove oxygen and add carbon dioxide so that you can test the lung's ability to work as a lung, to add oxygen and remove carbon dioxide. And we put everything that we've learned about how to protect the lung into this system so that it would protect the lung while we evaluate it. And this is what it looks like. Those are human lungs on the Torax lung perfusion system, which is manufactured here in Ontario. And you can see the lungs are perfused with a perfusion solution that doesn't have blood cells in it. They're breathing and they're at normal body temperature. You can put a bronchoscope in and bronchoscope the lungs. You can sample or you can deliver drugs. Here we're delivering the gene therapy that we're studying to modify lungs to make their own immunosuppression. And you can deliver that in the lungs and then continue to watch them over time to see if they are ready and good enough to transplant. And you can see here in our activity from the first lung transplant in 1983 to last year, we do about 200 lung transplants a year. And in yellow are the lungs that have gone on ex vivo lung perfusion. So it's really increased our ability to perform lung transplants. And in the recent era, we've really pretty well doubled the number of lung transplants we can perform. More importantly, though, in red here is the mortality or the chance of dying of a lung transplant operation. And you can see while we've provided more and more transplants, we've provided it with less risk, and our operative mortality is now 1.5%. We published this in the New England Journal, showing that we could take lungs that no one would use, put them on ex vivo and transplant them, and actually have equivalent lung transplant survival over the years. And I think that this is very important. It's also important to note we often quote a 5-year survival, a chance of making it to 5 years, but you can see that 30% of patients are still alive at 10 years and at 20 years after transplant. But our goal is really, can we make lungs that are better than the way we found them? Can we improve them? Can we make them so that they last forever? And we've been looking at IL-10, which is a cytokine, a communication molecule that downregulates inflammation and downregulates rejection. And we've been looking at, can we actually make lungs that make their own anti-rejection medication in the lungs so you don't have to take as many pills. We've also been looking at lung transplantation both as a career to attract physicians and surgeons into this specialty, but also for outcomes. And this slide shows that lung transplants done late in the middle of the night in green do slightly worse than lung transplants done in the daytime hours. And so we've looked at, can we actually move or schedule lung transplants to the daytime by preserving lungs better? And we showed that 10 degrees was a better preservation time. And I think the most important thing is to look at what's written in red here. We studied and showed that we had equivalent outcomes of lungs that were preserved up to 19 hours after transplantation. And here's the long-term outcome. This is a cooler we devised to keep lungs at 10 degrees. It'll keep them at 10 degrees for 24 hours. And you can see the outcomes of the 10-degree preserved lungs in red, or the regular preserved on ice or 4 degrees were the same. So it really gave us the capability and the flexibility to do lung transplants at any time. And what this does is it gives us the cold ischemic time, the time to transport the lungs to Toronto General, EVLP, which is done at normal body temperature, and another cold ischemic time where we cool them to move them into the operating time. And the question is, how long can we push this whole concept? We found out that normothermic, normal body temperature, ex vivo lung perfusion actually interrupts the lack of blood supply and recharges the lungs for the next period. And we actually studied this in pigs and showed that we could keep pig lungs for 3 days after taking them out and then transplant them and have excellent function. And this graph on the right shows that the oxygenation level was about 400, which is pretty much normal after 3 days of being outside of the body. So this really gives us, again, flexibility, but the opportunity to repair lungs. And this is the innovation we're doing, where we're looking at various different aspects of repairing lungs with drugs, energy devices, biologic materials, perfusion, inhaled gases, immunocloaking, and what I've been interested in is cell therapy and gene therapy. And this machine is the platform to apply these therapies. I'd just like to say a couple of words about precision diagnostics and artificial intelligence, because we've just, in transplantation, we preserve the organ and we rush and transplant it. But now we have the opportunity to apply personalized medicine to diagnose what's wrong with the lung and fix it. And we found biomarkers such as IL-6, IL-8 that tell you whether the lung is good or not, and whether to transplant it. So we're working at looking at more tests. We also take x-rays of the lungs, and we've used AI algorithms to read the x-rays for the physicians and surgeons doing the transplant to tell you that this is a good lung and that your patient is probably going to be extubated has a high probability of being extubated within 72 hours, or this lung is not suitable for transplant and don't do it. And now we've realized that we've got lots of information coming off the lungs. We've got information on the donor, we've got imaging, x-rays, we've got biochemistry, we've got biomarkers, and so on. So we've started to use artificial intelligence and machine learning to decide and to advise the physicians and surgeons on what lungs to use and which ones will be safe to use and which ones will not be safe to use. And we've developed a machine learning model called InsightX that actually tells you, transplant the lung, it's a good lung. Be careful, this one might have a slightly longer ICU stay, but being in the ICU more than 3 days is not a failure. It's not what we would want, but it is, a longer stay. Getting extubated and out of the ICU in less than 3 days is really what we aspire to. Or don't transplant that lung, it's going to be dangerous or there's a problem. And so we've used this in looking at gene therapy, using CRISPR editing of the lungs, developing universal lungs, and various types of immunomodulation. We're also using AI to develop the concept of a digital twin, which is used in automobile and aviation. Like, you don't have to crash a plane to know it's not going to fly properly. And the same token is, can we predict how the lung's going to be in 4 hours or 4 years from now? And I think with this, we'll be able to know the outcomes of lung transplant and accelerate our research and select our treatment. I'd like to give you a little bit about results of lung transplant. As I said, the 5-year survival on average now is about 7 years. Sorry, these 50% or median survival is about 7 years now. But many patients don't understand that, and they don't realize that many patients live many years, 20, 25 years after transplant, and about a third of them are alive at 20 years after transplant. But we'd like to increase that number to make the goal in our research lab is make lungs that last forever. And the problem with lung transplantation long-term survival is chronic lung allograft dysfunction, or CLAD it's called. In the green is the most common cause of death in the latter years, and infection, because you're immunosuppressed and your ability to fight infection and cancer is depressed. We also have no age limit in transplant. So you can see the transplants done for people less than 50 is slightly better. These are the ones for the over 70. Now you can see in the early years, it's very similar. We pick very carefully and evaluate patients very carefully to be able to get through a lung transplant operation. And obviously, we're not changing the survival of the human species, so they don't live quite as long if you do a lung transplant after the age of 70. We also benchmark very carefully to compare our results to the rest of the world and the United States through this database SRTR, showing to make sure that even though we're the largest lung transplant program in the world and probably the most aggressive and innovative, we still have superior results. Marcelo Sippel has been working on some very unique aspects where they use an enzyme called abiozyme to remove the A and B antigens to make O lungs, so that you have a universal donor lung. Many times, short stature women of blood type O wait longer and die more often on the wait list. So having a universal lung is really the way to go. I talked about IL-10, anti-rejection built into the lung. And we did the studies to show that if you transduce the lungs with the IL-10 gene therapy before transplant, you have better lung function after transplant. This is in rats on the left, and on the right is in pigs. And here, this rainbow color is bioluminescence imaging, which shows that this lung in the rat was making its own immunosuppression for over a year after transplant. So therefore, the idea is that you wouldn't have to take as much or any pills by mouth. Kumi Misaki just finished her PhD with us, and she's learned how to do CRISPR gene editing of the lung so that it makes its own immunosuppression. So we use adenoviral vectors in the pink graph there to make IL-10 in the early period to make the lung function immediately after transplant. And then the CRISPR IL-10 kicks in, and that's gene editing to have the lung make its own immunosuppression forever. So this is something that we want to bring clinically shortly to do the first in human transplants of gene edited lungs that make their own immunosuppression. We've been doing this with gene therapy, and we're also doing it with cell therapy. This is a very exciting experiment that Dr. Juvet, who's one of our respirologists, is doing with me, where he takes the regulatory T cells, the anti-rejection T cells, puts them into the lung before the transplant, and then you get the lung transplant with regulatory T cells that are yours in it. So really, we've transplanted the lung in the context of self so that you don't reject it. So that's a very exciting opportunity. And we have this whole pathway to bring things from cells to rats and mice to pigs ex vivo, human ex vivo lungs, and then clinical trials. We're also helping the rest of our transplant program. This was our prototype ex vivo lung perfusion device. And we've been working so that we could figure out ex vivo heart with our heart team that are trying to repair hearts and make hearts better for transplant. Our liver team, you can see the liver requires blood for perfusion, and they're studying that. There's a kidney, ex vivo kidney machine as well. Again, we've built prototypes, and now we're building it into machines that they can use clinically. And then finally, the pancreas to treat diabetes or pancreatic insufficiency. Some very exciting work being done in that area by Dr. Trevor Reichman. So what we've learned in lung, we're moving into the other organs. I think the future state of organ transplantation is organs will be retrieved, brought to an organ repair center, optimized, and then shipped out to different transplant centers for the patients, optimized for the specific patient. And you may think this is science fiction, but we built this in 2008 in Toronto, and this is the Organ Repair Center at Toronto General. We have 3 rooms for modifying organs, and we partnered with United Therapeutics to build lung bioengineering. This is a facility in Silver Spring, Maryland that can handle up to 1,800 lungs a year. It looks like that. Those are organ perfusion specialists that do EVLP on the lungs. They were all trained at Toronto General Hospital, and you can feed the information to the surgeon on their iPhone. So I can look into the lung, I can see the bronchoscopy, I can see all the numbers, the oxygenation, and decide whether the lung is usable or not. So we started in Toronto, we're in Silver Spring and Jacksonville, and now building in Phoenix, Arizona to put lung repair centers across the continent. And we're hoping that we can serve Vancouver and Edmonton from Phoenix as well. So I think, the current aspect is you take lungs from a donor hospital, you ship them, fly them to the transplant hospital. I think in time to come, you're going to stop off at organ repair centers, fix the lung, optimize it, and then transport it for transplantation to the recipient hospital. When you think about it, we send a plane each time to carry an organ, and why don't we just use drones? And so we've been working to develop drones. This is a drone carrying a lung across the Toronto skyline that we transplanted. And I think in time to come, we're going to send drones to Halifax or to Vancouver to pick up a lung so we can then transplant it. That's landing on the top of the roof at Toronto General Hospital, where we subsequently transplanted the lung. And this was the first delivery of human lungs by a drone in September 2021. Kevin Smith is our CEO on the right of the picture, and Martine Rothblatt, the CEO of United Therapeutics, on the left, that helped us to bring this project to fruition. So, I've showed you a lot of the innovations. We have a large laboratory. We have 150 people working on research in lung injury and lung transplantation. This is almost the whole group. And of course, The most important group is our clinical lung transplant team here shown at our retreat. And this is really where a team that really goes the extra mile for our patients and is courageous to bring all of these innovations to the bedside. So I'm going to stop there and hand over to Aman, who will talk to you about the other stuff.
Great, thanks, Shaf. I'll just get my screen up and make sure that it's working okay.
Thank you very much. I just want to remind everyone, if they have questions popping up, if you can put them in the chat, we can address them at the end. And I'll turn it over now.
Can everybody see that okay?
Yep.
So I'll move on and focus a little bit on challenges in lung transplant care for the Maritime Canadian patient. And really it applies to, of course, the Maritimes, Newfoundland, and people who are more remote from our center. We never talk in our program about challenges without thinking about opportunities. So along the way, and part of the discussion, I think will be important to highlight some of the opportunities that may be possible through further collaborations with our colleagues and patients out east. You heard a little bit about the geography of lung transplantation, but I always like to paint this picture that, here in Canada, as a giant country, we have 4 lung transplant programs highlighted by the stars, the red one being Toronto. And, that's very different than in the United States. There's 75 programs, and it looks a little crazy to have such a vast geography. We have, in Toronto, as you know, we serve the East Coast, but we also take higher risk referrals from all over the country. And, there is a benefit to centralizing lung transplant care. There's something to be said for experience, and we know that it's linked to better outcomes. But it does come at a cost to longer term follow-up, to access, and having to think outside the box and be innovative in how we provide care for people who need lung transplants. You've seen this slide that illustrates our numbers, but I just want to point out that we follow currently a prevalent population of about 1,300 lung transplant recipients, and about 15% of those patients are from the Maritimes and Newfoundland. So it's a decent amount of patients who we both see in referral and follow over time. So I want to walk through the lung transplant journey, kind of from the point that we meet people or they're referred to us, and what some of the challenges are along the way, and think about some of the opportunities that we may have. But I think it is important for awareness to highlight these, and I think people on this call would likely be able to point out some other ones that we may be missing and may not have the same perspective on. In terms of referrals, we see about 600 patients annually in terms of the referrals that we get. And so about 90 to 100 are from the East Coast. We've set benchmarks to being able to see people within a week if the referral is urgent, and less than a month if it's a routine referral. We've set benchmarks for our assessments and think that they should be completed within a month if it's a very urgent assessment, sometimes faster for a hospitalized patient, and less than 3 months on a routine basis. The listing period is very variable. Our median wait time is more recently been in the range of 3 to 4 months, but again, that's a median wait time. That it's important to understand there's people on both ends of that. And then the transplant period, which I won't talk about so much in detail, but that involves about 3 months in Toronto from the time of the surgery itself, and about 3 weeks is a median hospital stay. And of course, lifelong follow-up post-transplant, which comes with its own challenges and opportunities. And just to highlight this timeline between the listed period and the post-transplant period is not predictable on an individual basis, although we looked at survival statistics. So starting in the referral phase, I guess the first question is, do we even have good data on referral for transplant? And really the answer is no. This is older data on rates of transplantation per million population from Statistics Canada. One question is, how accurate is this data? I'm not sure. I think what it displays is that there may be a lower rate of transplant in the Atlantic provinces per million of population, but what we don't really have is data on referral rates for transplant. That's true in Ontario as well. How many people are actually getting to the point of being referred for transplant, and how many people are living with advanced lung disease? I think to be able to start to improve the quality of our care, we have to start with this kind of data. I do think that this slide may illustrate one issue, being the access to referral to transplant. Our own experiences, a lot of varied knowledge around indications and contraindications to transplant and when to refer somebody for assessment with us. So this is, I think, one opportunity is just looking at this data and trying to look at points of improvement for referral. The consultation phase, I think we're pretty good at. We meet these benchmarks, and we've been able to meet them even for people living at a distance because we've leveraged virtual care in our program for a really long time, over 15 years. So before I joined the program, telemedicine was a thing, and about 40% of our patients were seen virtually in consultation, which allows them to be seen relatively quickly and doesn't compromise outcomes, both for their evaluation for transplant and longer term follow-up. That's really important for patients on the East Coast because many are not able to travel or may not need to travel for an in-person appointment that is an initial information exchange. There's, of course, both safety and improvements for people who don't need to get on a commercial flight on oxygen, and then some cost savings and satisfaction rates that we've been able to demonstrate. When we get to the assessment for transplant, once you have a consultation and start to move through the process, this is when things get, for lack of a better word, a bit wiggly and a bit more difficult. This is just an illustration of the basic assessment tests that we arrange for people when we're looking at them as a potential lung transplant candidate. And none of these tests are unusual or uncommon, but they're not available at every hospital. And so, that starts to introduce some potential delays. So what are some of the challenges? Well, in speaking to our teams who work in arranging these assessments, we're really not right now meeting these less than 3-month benchmarks for assessing patients who are on the East Coast. And there's several issues that I think exist. One is just arranging assessments for people who are out east and not traveling to Toronto, is challenging. We have to coordinate care with multiple different referring physicians and centers, particularly in PEI, New Brunswick, and Newfoundland. I've left Halifax out because we're going to highlight the wonderful work that the Halifax team has been doing. There can be a really long wait time for testing in some of the Maritime provinces, and some wait times are up to 4 to 6 months for some of these tests, which of course can introduce delays, which can be life-threatening for some individuals. We, as the transplant team, the physicians, can't always order tests due to licensing issues in local centers, and so again, we're trying to coordinate with other physicians and teams. And despite it being 2025, we have no integration interprovincially of electronic medical record systems. And that's a big challenge. It really introduces a digital divide for people outside of Ontario. Don't get me wrong, we use you'll see a picture of a fax machine for those of us who maybe, or those people on the call who are younger, you might not even know what this is, but we use them a lot in medicine. But one thing that we do have in Ontario is a province-wide viewer called the Connecting Ontario Clinical Viewer. So even if we're not getting results sent to us, we can pop on this viewer and find most of the results. We also have an increasingly integrated system because many centers are moving towards the EPIC electronic medical record system, where we can see results from other centers. So if somebody is getting testing done in Ottawa, I can see that within our system because they're all on EPIC. That doesn't exist interprovincially. So our teams are really working hard using faxes, phone calls to try to coordinate care, get testing done. But inevitably, this introduces further delays in being able to move people through the system, particularly when you're doing something inefficient, but with multiple people involved. As part of the assessment, we also have multiple consultations with experts on our team. It's of course not just the physicians and surgeons. We have meetings with our nurses to ensure appropriate education, to make sure that we're assessing people's physical abilities, anesthetic concerns, providing support from social worker, and for nutritional support. And there's been challenges that have come up over the years, and particularly more recently with respect to licensing of various members of our team. For example, our nurse coordinators have a nursing license in Ontario that's not recognized in some provinces, particularly PEI or New Brunswick. Some of our allied health members also need additional licensing to be able to practice virtually in other provinces. Right now, we're not able to have our expert physiotherapists provide assessments remotely for people who are out of province, and that's a really big part of our assessment. We have found, and it's not just on the East Coast, but in sometimes more remote places in Ontario, local allied health resources are limited, and trying to work with people locally doesn't always provide the support and assessment that people need. But we are working through adding licenses for all of our allied health staff and sort of providing that from the transplant program. One of the other challenges we faced on the physician side is some limitations on virtual care provision by physicians. It's actually an Ontario problem, and it's changes in the Ontario, the Ministry of Health allowing things like billing for patients being seen out of province. We saw our numbers. We have a big number of people who we see in consultation and who need follow-up. So we have been able to work with each province to allow ongoing care access, but we need to ensure that that's a sustainable solution. So there is one, existing solution that addresses a lot of the challenges that we've mentioned so far, and that is satellite care. And many of you know that there is a satellite program in Halifax, and some of that team I think is on this call, who helps to run a really important program that we collaborate with. And Dr. Meredith Chiasson has been a big part of that program. Scott McPhee, who's a nurse practitioner in the program. And soon you'll have Dr. Alexandra Dittrich, who will be coming back to Halifax after training with us. You're lucky that we're letting her go because we would love to keep her, but you're very lucky to have her to join the team. And, I think that this is really one place that we need to go to have really formal satellite care programs with ongoing links with us. What we've started to do, even as an interim in Ontario, is perhaps not having the expert teams ready to go, but starting to work with local hospitals or particular centers to coordinate assessment testing and other testing. So at least you have a single point of contact of sorts, where we are, for example, in Ontario, we don't have a satellite program in Ottawa, but we arrange certain assessments within the Ottawa hospital instead of working with multiple smaller sites. But these teams and the connections that we have with them are really key, and a key opportunity to build upon. I'll move on to the listed period, which I think ends up being one of the most difficult for people. One, because of the uncertainty of the timing and how long people need to be here in Toronto. But once you're listed, you do need to be within 4 to 5 hours of Toronto General. This used to be, the requirement used to be within about 2.5 hours of Toronto. We've been able to loosen that up because of things like Shaf talked about, with better organ preservation, and have people waiting, up to 5 hours away within the province. Of course, if people need to be closer, it's because they're less stable, not able to travel back and forth for things like their regular physiotherapy appointments and appointments with us. But many of you are familiar with some of the news stories that have highlighted these challenges, particularly coming out of Nova Scotia. In 2019, there was a big story about, people who were unfortunately feeling like they could not manage the financial aspects of moving to Toronto to wait for a lung transplant, and choosing or exploring options like medical assistance in dying. That did lead to some boost in provincial funding, which has been important for patients. But, fast forward 5 years later, there's still issues with funding. And a recent news story from a patient who was a recipient in our program, who had a lot of financial difficulties with the waiting period and the costs in Toronto. It's probably not surprising to people that the cost of rent, this is just the greater Toronto area, not even reflective of downtown, but these rents have increased hugely over the last number of years. And the average furnished condo near our hospital is $3,500 to $4,500 a month. That below that, you can see what the monthly reimbursements, I hope these are correct, but that they barely meet or don't meet even a monthly rent allowance. and that there's limited support for caregivers who need to be here as well with patients to support them through the process, many of whom may be of working age and then leaving behind jobs and getting limited support, while they're not working. There's other challenges that I think should be looked at as opportunities for improvement. There is a prior approval process for most provinces, and the awareness for patients and the ability to navigate these processes, I think, needs some work. And this is in discussion with our wonderful social worker. These programs are also reimbursement only. So people have to have money up front to pay, sometimes for many, many months of expenses. And imagine that can be so daunting when the expenses are extremely high and you have no real sense of how long you may be here. There's, of course, very important but less tangible barriers that people have to consider and can, start to add up along with the finances. Some of the opportunities we've thought about over the years is whether we could do something like have maritime patients wait at home for a lung transplant. And, some of the work that's being done on preservation may allow this. I think there's some risks to consider on a population and individual basis, how people can get to Toronto, if they're able to fly on a commercial flight or if it has to be a medical flight. Some risk of not making it here in time due to inclement weather, and access to care locally if somebody's waiting at home, and can they still get good rehabilitation that keeps them fit for transplant, the rest of the support they need, and maintain an ongoing connection with our team. I'll talk a bit about what post-transplant looks like, and I'm not meant to go through all this, but this is just to illustrate what our follow-up is for people both early and lifelong. There's a lot of testing that we do and a lot of things that we monitor for patients to make sure that we can hopefully detect changes and provide a good outcome in the short and long term. But when people return back home after that initial 3-month period, we still need to have them come back every 3 months for certain testing, particularly surveillance bronchoscopies. Being able to organize testing locally is a big lift, similar to the assessment tests. And being able to reliably get these test results back in a timely manner so we can act on them. Just acting on the test results can be very challenging from, out of province as a care provider without having a center like a satellite center to help coordinate things with. And then, of course, we face similar issues in the post-transplant period with licensing and virtual care provision. The digital divide applies here too. Without connected EMRs, we're not able to be as efficient. And detecting these post-transplant complications, you saw some of the reasons that people may not do as well, or they may die after a lung transplant. And, if we can detect these changes earlier, then people are better off. Not only that, if we can have a good flow of information and detect issues before people are really unwell, admitted to the hospital, it also reduces costs and improves quality of life for patients. And so one opportunity that we look at that I'll talk about quickly is better ways to monitor lung transplant patients from a distance. Well, one really important thing for a transplant recipient is looking at their lung function. And so we've been really working on trying to improve pulmonary function testing at home. The technology for home monitoring for pulmonary function tests has come a long way. This is just an example of now the spirometer that we use in our program, which provides full flow volume loop data and validated results that meet ATS criteria for spirometry. So now lung transplant recipients can check this lung function at home, and actually we get the results sent to our EMR directly. We were able to partner with a group of our wonderful patients to pilot these spirometers and implement them and really co-design the materials that people use to train. And we measured things like ease of use, how well did people use them, and how well do they correlate. And again, the wonderful thing is that this is all integrated in with the patient portal, which patients already use for communication with our team, access of educational materials, and tracking of appointments. And these work really well. All of our patients reported that they have ease of use. There's a high adherence rate. And I'm sorry for the blurry images, but there's a really strong correlation between in-lab testing and home spirometry. The best part is this all flows into the EMR. So if I am open, if I'm seeing a patient or even in between, I get all these results, and we get alerts sent to our team if the results are out of range. Outside of spirometry metrics, you can see there's other metrics that we can collect: oxygen saturations, heart rate, blood pressure, and a really whole like kind of connected system that we can create for patients to monitor people from a distance that we'll be building upon. The last thing I'll talk about just quickly as a complementary piece is work that we're doing that's really being led by Dr. Jonathan Young, one of the surgeons in our program, looking at innovative blood tests to monitor problems with the lung transplant graft. So donor-derived cell-free DNA, or DNA fragments, to put it simply, that can help to alert to issues with your lung transplant. And, this is a blood test that can be drawn at any facility. It doesn't mean you have to fly to Toronto and get a bronchoscopy done. And it can provide an early signal of organ dysfunction and be a trigger for other testing. There's still some issues to sort out with further research in that, these changes in cell-free DNA may not be specific, or they may not, it may not rise. But I think, correlating this with other remote monitoring solutions will go a long way. I want to highlight again, in the post-transplant phase, the opportunities we have. I mean, working with Dr. Chiasson and the team, if somebody who runs into a problem after transplant needs an intervention, whether it's treatment for rejection or other, it's so much more streamlined and provides such high quality of care to have a center where people can go, where there's expertise and streamlined communication with our center. And so that hopefully runs through the lung transplant journey and just some of the challenges and opportunities. But to highlight them in summary, I think that there's a lot of different things that we can improve upon. I mean, one is just starting with awareness of transplant for patients and providers, looking at how to increase. There's not unlimited funding, we realize, but in a realistic way, increasing supports for patients who need to come for a life-saving surgery, improving how we look after people at a distance, innovations that you heard about in organ preservation for scheduled surgeries, expansion of satellite clinics for non-surgical care, and really investing in studying barriers and geographical or outcomes based on geography so we can continue to improve our care for people at a distance, and particularly for our big population in the Maritimes. So I'll stop there and hopefully leave time for questions and comments in the last few minutes.
Fantastic. Thank you very much, Dr. Keshavjee and Dr. Sidhu, for those innovative and informative talks. Very inspiring.